Assalamualaikum. Our group will discuss about the rhetoric based on these reference books. So the first one, the overview. There are many classifications of the rhetoric, such as thiazide that inhibits sodium chloride, sodium ion chloride ion resorption in early distal convoluted tubule. Loop diuretic inhibits sodium ion, potassium ion chloride ion co-transporter in PAL of Henry's loop. And carbon anhydrase inhibitor like acetylcholine inhibit HCO3 reabsorption in proximal tubule. Potassium diuretic, potassium sparing diuretic like spironolactone and amiloride inhibit sodium ion or potassium exchange in collecting duct. For dietary management, importance of diet in conditions like hepatic encephalopathy emphasize the protein restriction and high quality protein intake. Sub-restriction combined with a moderate protein restriction is beneficial to prevent renal failure. For the users, thiazide can be used to treat hypertension, mild cardiac failure, edema, and for loop diuretic can be used to treat heart failure, chronic renal failure, hypercalcemia. Potassium sparing diuretic can be used to treat heart failure, hyperaldosteronism. Carbon anhydrase inhibitor can be used to treat glaucoma. Osmotic diuretic can be used to treat acute renal failure and IOP reduction. First, adverse effect and interaction on the diuretic. Generally, adverse effects of diuretic include acute renal failure, hyperkalemia, hypomagnesemia, hyperuricemia, hepatotoxicity, and metabolic alkalosis. Loop diuretic can increase nephrotoxicity of certain antibiotics and reduce victim reabsorption. Thiazide diuretic have specific adverse effects and potassium sparing diuretic usually well tolerated but can cause hyperkalemia. For disease management, there are usually two diseases. The first one is salt and water overload disease, which condition is heart failure, renal failure, nephrotic syndrome, and cirrhosis. The treatment is dietary sub-restriction, diuretic administration such as thiazide, loop diuretics, potassium sparing diuretic. The second one is hypokalemia. Causes is vomiting, diarrhea, diuretic therapy, mineral corticoid excess. The symptom is fatigue, dystonia, notoria. Management can be used is we need to address underlying causes, potassium supplementation, and use potassium sparing diuretic.
Now we move on to angiotensin converting enzyme inhibitor, which is called ACE inhibitor. This drug functions to reduce blood pressure in order to treat hypertension, heart failure, and recent myocardial infarction. And this is the example of ACE inhibitor, and as we can see here, most of them ended with pril, enalapril, ramipril. So the drug that have pril at the end of the name is ACE inhibitor. Now we move on to the mechanism of action of the ACE inhibitor. So ACE inhibitor will inhibit the formation of angiotensin 2 from angiotensin 1, and this will reduce the blood pressure and reduce the blood volume. And here are the side effects of ACE inhibitor, which include headache, dizziness, fatigue, and the most common one is dry cough. And these are the other side effects, which include tachycardia, hypotension, and hyperkalemia. And the contraindication for ACE inhibitor is that it can't be used with the patient that take potassium sparing diuretic like spironolactone, patient that have renal insufficiency, and patient that have pregnancy, because this drug may cause fatal injury. And now we move on to the one of the liver disease, which is cirrhosis. Cirrhosis is inflammation and damage on the liver cell, which called fibrosis, and this will cause irreversible scarring to the liver, and it caused by mainly alcohol consumption or prolonged viral attack. And the symptoms of cirrhosis include jaundice, ascites, which is fluid retention in peritoneal space, easy bruising, and hepatic encephalopathy, and it can be diagnosed through biopsy or lab tests. And the treatment for this disease is by treat the underlying cause, or even we need to have liver transplant.
A case report has shown that an 80-year-old retired publican presented with congestive cardiac failure and acute urinary retention. His symptoms had been worsening over 6 months despite increased water tablet dosage for hypertension. Recent confusion and restlessness prompted chlorpromazine use. He had a history of frequent urination and was found anemic with a palpable bladder and an enlarged prostate. Emergency treatment included catheterization, diuretics, and hemodialysis. A bleeding gastric ulcer was discovered during gastroscopy. However, how did each pre-admission medication potentially contribute to the patient's condition? The answer for the question is by the medicine he take. The first is coamylazide, which risked hyperkalemia due to amiloride and exacerbated prostatic symptoms from thiazide. Next, chlorpromazine, which contributed to urinary retention. The third drugs is ketoprofen, which associated with gastric ulcer, possible antagonism of thiazide diuretics, salt retention, and potentially interstitial nephritis. The last drug is magnesium trisilicate mixture, when added sodium load detrimental in cardiac and renal failure, for the explanation of answer. Multiple medications in the elderly can induce iatrogenic diseases. Amiloride in renal impairment can lead to hyperkalemia, possibly contributing to confusion. Chlorpromazine might mask reversible organic diseases. Ketoprofen's use in osteoarthritis is questionable due to its risks, while antacids like magnesium trisilicate can worsen cardiac and renal failure due to their sodium content.
For the heart failure occurs when the heart fails to deliver adequate amount of oxygenated blood to the tissues during exercise or in severe cases at rest. And the therapeutic objective in treating heart failure is to improve symptoms and to prolong survivals. And principle of treating heart failure is by restricting dietary salt, and if there is hyponatremia, we should restrict fluid and consider anticoagulation on an individual basis. And for the drug for the heart failure, the first one is diuretic, which is furosemide and spironolactone. The second one is angiotensin converting enzyme inhibitor, which is captopril and ramipril. The third one is angiotensin receptor antagonist, which is sandersartan and valsartan. The fourth one is beta adrenal receptor antagonist, which is atenolol, metoprolol, and labetalol. The fifth one is aldosterone antagonist, which is spironolactone. The sixth one is combined hydrolyzing with organic nitrate therapy. The seventh one is digoxin, and the last one is other positive inotrope, which is milrinone.
Hypertension. Thiazide diuretics like chlortalidone and bendroflumethiazide are preferred for mild hypertension in older patients and Afro-Caribbeans, reducing stroke risk better than beta blockers, taken once daily. Loop diuretics are better for hypertension with kidney issues or heart failure. Mechanism of action. Thiazide diuretics lower blood pressure by blocking sodium reabsorption in the distal convoluted tubule, promoting sodium excretion. Despite initial plasma volume increases, blood pressure normalizes over time. They also reduce peripheral vascular resistance and sensitivity to pressor agents with chronic use. Adverse effects of thiazide diuretics include metabolic and electrolyte changes, erectile dysfunction, increased plasma renin levels, limiting antihypertensive effects and idiosyncratic reactions. Contraindication. Thiazide diuretics should be avoided in severe renal impairment, history of gout, preeclampsia, and men with prostatic symptoms. In patients experiencing diarrhea or vomiting, temporary discontinuation is advisable to prevent further fluid depletion. Drug interactions. Diuretics interact with lithium, increasing its plasma concentration and toxicity. Hypokalemia and hypomagnesemia worsen digoxin toxicity. Combining thiazides with potassium-sparing diuretics can prevent excessive hypokalemia, useful for medications prolonging the QT interval. Non-steroidal anti-inflammatory drugs, NSAID. The mechanism of action of NSAID involves the inhibition of prostaglandin synthesis. You can review it on your own. Adverse effects of NSAID include stomach issues and reversible kidney impairment, especially in elderly or those with kidney conditions, mitigated by omeprazole or aspirin. NSAIDs also interact with antihypertensive medications, worsen heart failure, and affect sodium excretion, lithium clearance, and potassium levels, necessitating close monitoring in patients on maintenance lithium doses.
Nephrotic syndrome. The problem that causing the nephrotic syndrome is, firstly, impairment of the barrier function of the glomerular membrane. Next is the leakage of the plasma albumin into the urine. So, the consequences of these two problems causing plasma albumin concentration will fall together with the oncotic pressure. Next, the water will pass from the circulation into the tissue spaces that can cause the production of the edema in that tissue. Next is it can cause stimulation of the renin-angiotensin-aldosterone system, causing sodium retention. So, the treatment that I suggest to treat the nephrotic syndrome is, firstly, to reduce the albumin loss, we can use the glucocorticosteroid or other immunosuppressive drug. Secondly is the diet. Third is adequate protein intake. And fourth is salt intake should be restricted.
For the potassium sparing diuretic, it consists of two categories, which is competitive antagonists, which are spironolactone and eplerenone. The second one is natrium or kalium exchange antagonist, which is amiloride and triamterene. For the osmotic diuretic undergo glomerular filtration but are poorly reabsorbed from the renal tubular fluid, and the example is mannitol. And for the volume depletion, for the principle of fluid replacement, can be treated with replacement with glucocorticoid and mineral corticoid hormones. And for the disorder potassium ion balance, consists of two, which is hypokalemia, which are the lack of potassium ion due to diuretic therapy. The second one is hyperkalemia, which is excess of potassium ions, and it can be treated with emergency hemofiltration or dialysis. And for the method of potassium replacement, it can be done by potassium supplements and potassium sparing diuretic. And the drug that alter urine pH is acidification like ammonium chloride and alkalinization like sodium bicarbonate. The drugs that affect the bladder and genital urinary system is, the first one, drugs to increase bladder activity like beta-alcohol and distimine. The second one is drug for urinary incontinence like doxazosin and oxybutynin. The third one is the drug for prostatic obstructions like finasteride and doxazosin. The last one is the drug for the erectile dysfunctions like sildenafil or Viagra.
Volume overload is usually caused by an excessive sodium chloride with accompanying water. Effective treatment is directed at the underlying cause like heart failure or renal failure. In addition to improving volume status per SE by reducing salt intake and increasing its elimination by the use of diuretics. Limiting water intake is seldom useful in patients with volume overload, although modest limitation is of value in patients with ascites due to advanced liver disease and in other patients with hyponatremia. Diuretics increase urine production and Na plus excretion. They are of central importance in managing hypertension, as well as the many diseases associated with edema and volume overload, including heart failure, cirrhosis, renal failure, and nephrotic syndrome, where it is important to assess the distribution of salt and water excess in different body compartments. Glomerular filtrate derives from plasma, so diuretic treatment acutely reduces plasma volume. It takes time for tissue fluid to re-equilibrate after an acute change in blood volume. Consequently, attempts to produce a vigorous diuresis are inappropriate in some oedematous states and may lead to cardiovascular collapse and prerenal renal failure, i.e. caused by poor renal perfusion, often signaled by an increase in serum urea disproportionate to the creatinine concentration. The principles of using diuretics in the management of hypertension and heart failure are described elsewhere. Here, we describe briefly the management of hypoalbuminemic states, for example nephrotic syndrome and cirrhosis. Hypoalbuminemia affects the kinetics of several drugs through its effects on protein binding and causes an apparently inadequate intravascular volume in the face of fluid overload in the body as a whole. This results in an increased risk of nephrotoxicity from several common drugs, particularly nonsteroidal anti-inflammatory drugs. Particular caution is needed when prescribing and monitoring the effects of therapy for intercurrent problems in such patients.
Lastly is a weight loss. The drug that causing the weight loss is a first loop diuretic drug, which is furosemide. Next is thiazide diuretic drug, which is hydrochlorothiazide. Next is potassium sparing diuretic drug, which is spironolactone. So, the action of all these drugs will cause it increasing in the urine production and increasing in the excretion of the water and electrolyte. So, the consequences of this action is weight loss due to fluid loss through the increasing the urination. So, the side effect that might happen is excessive fluid loss can lead to the dehydration of the body because body lost so much water. Next is electrolyte imbalance if not we manage properly.